Welcome to the April 2025 educational event. I'm Kavya Velagapudi, Executive Director of the Neuroendocrine Cancer Foundation.
And I'm Lisa Yen, Director of Programs and Outreach.
And I'm Heather Davis, the Associate Director of Advocacy and Outreach for the Neuroendocrine Cancer Foundation.
Today's presentation is on understanding treatments for neuroendocrine tumors and rationale for sequencing of therapy. A special thank you to our supporters, Novartis, Ipsen, Exelixis, Curium, Crinetics, ITM, Boehringer Ingelheim, and InterScience Institute. We're pleased to share that LACNITS is now the Neuroendocrine Cancer Foundation. This rebranding signifies the strides we made in reaching more patients and caregivers, and also in offering more educational and support programs. You will see our new branding being rolled out on our website, social media, and all communications. We appreciate your patience during this transition. Our team remains the same. Our staff includes Lisa Yen and Heather Davis. Our board includes Donna Gavin, who is the sister of our founder, Giovanna Joyce and Daisy, and NET patient Mary Dunleavy, who has been living and thriving with NET for 20 years. Neuroendocrine Cancer Foundation will continue to collaborate with the Carcinoid Cancer Foundation to provide its programs, including the Luncheon with the Experts and support line. Now I'll hand it over to Heather.
Thank you, Kavya. Our YouTube channel features over 400 educational and wellness videos, testimonials, and podcasts. Click videos or playlists to find patient and caregiver stories, information on types of treatments such as PRRT, liver-directed and targeted systemic therapies. There is information on imaging, nutrition, and our annual conferences. And you can also find our educational videos by topic or in our video library on our homepage, ncf.net. As we transition from LACNITS to Neuroendocrine Cancer Foundation, you can still find us on social media, Facebook, X, and Instagram with our new handle @NCFCancer. And be sure to add us to your Safe Sender email list. I'd like to remind our audience that our webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this webinar are from the experts' experience and insights. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it over to Lisa.
Thank you, Heather. I've been supporting my husband, who was diagnosed with neuroendocrine cancer in 2015, and together we aim to stay informed and engaged with clinical trials as possible treatment options throughout our 10-year journey. We understand at the Neuroendocrine Cancer Foundation that one of the challenges is finding and understanding clinical trials that are right for you. And this is why we created a clinical trials guide, meant to be a easy-to-use educational resource that features several key clinical trials for neuroendocrine cancers. You can browse the site by the type of neuroendocrine cancer, such as GI, pancreas, lung, or high grade, or the types of treatments, including PRRT and other types of treatments. When you click on each clinical trial, you will find brief patient-friendly videos on many of them, and also information about each trial. We hope that our clinical trials guide can help you better understand clinical trials that might be available for you. I'm pleased to introduce our speaker for today, Dr. Edward Wolin. Dr. Wolin is an internationally renowned authority on neuroendocrine cancers, and he currently serves as the director of the Center for Carcinoid and Neuroendocrine Tumors at the Tisch Center Institute at Mount Sinai and professor of medicine, medical oncology at the Icahn School of Medicine at Mount Sinai. Dr. Wolin has pioneered innovative therapies for neuroendocrine cancers, many of which are familiar to you, such as somatostatin analogues, targeted therapies, peptide receptor radiotherapy, or PRRT. Prior to joining Mount Sinai, Dr. Wolin was the director of the Neuroendocrine Tumor Program at Mount Fiore Einstein Cancer Center, and previous to that, he worked for more than 2 decades with Cedars-Sinai Medical Center in Los Angeles, where he founded and directed one of the largest neuroendocrine tumor programs in the country. And subsequently, he directed the Neuroendocrine Tumor Program at the University of Kentucky. During Dr. Wolin's 2 decades at Cedars-Sinai Medical Center in Los Angeles, he developed a close friendship with our founder, Giovanna Joyce Mbesi. Dr. Wolin was instrumental in the founding and development of LACNETS, which is now known as the Neuroendocrine Cancer Foundation, and he guided us in our early stages and has been a host, speaker, and supporter for our in-person educational programs when we were a local support group in Los Angeles, and later in our virtual programs as we have since grown, and he continues to be involved, and we really treasure our long history and close friendship. Dr. Wolin says that LACNETS, and now the Neuroendocrine Cancer Foundation, has always been very dear to his heart, and he cherishes and honors the memory of Giovanna. We too cherish his friendship to our founder and to our organization. And most of all, we are grateful for his contributions to the neuroendocrine cancer community at large. Welcome, Dr. Wolin.
Hi, my name is Dr. Edward Wolin. I'm a medical oncologist at Mount Sinai Medical Center in New York and a specialist in neuroendocrine tumors. I'm a neuroendocrine medical oncologist and director of the Carcinoid and Neuroendocrine Tumor Center at Mount Sinai, and also professor of medicine at the Icahn School of Medicine at Mount Sinai. And it's my great pleasure to speak to you today on understanding treatments for neuroendocrine tumors and rational sequencing of therapy for these tumors. I'm just going to jump right in and give you a little bit of a background to make the rest of the talk more understandable, and then we'll dive into the main subject. First thing to remember about these neuroendocrine tumors is they're really divided into 3 major categories, depending on where they might have originated if you were an embryo. They're called foregut tumors, midgut tumors, or hindgut tumors. And as you can see, the foregut tumors include ones that start in places like the lung, the esophagus, thymus, stomach, duodenum, or pancreas, which is actually a foregut tumor, but a special category. Midgut tumors that are usually in the ileum, the last part of the small intestine, or the appendix, or the beginning of the colon. And the hindgut tumors, which involve the rectum and the last part of the colon. The next thing to remember about these tumors, other than site of origin, is the grade. Grade of a tumor is distinct from stage. Grade of tumor refers to how fast the tumor is growing. And they are called well-differentiated tumors or poorly differentiated tumors. The well-differentiated tumors can be grade 1, grade 2, or grade 3. And as the grade increases, the speed of growth increases. And this can be quantitated on pathology analysis, with less than 2 cells dividing by Ki67 is called grade 1, 2 to 20% is called grade 2, and more than 20 is called grade 3. One additional point to remember is that grade 3 has another category of high-grade neuroendocrine carcinoma, and there's a group of neuroendocrine tumor, grade 3. The neuroendocrine tumor is well differentiated, the neuroendocrine carcinoma is poorly differentiated, and the treatments for these are very different. So it's important that the pathology be read by somebody who's an expert and understands the subtleties of these grades, and a very accurate grading is done on the tumor. Third important thing to remember is the cancer one which is making a lot of hormones, making people sick from hormone production, or is it just growing and doing whatever nasty things cancers can do by direct growth? If a tumor is a so-called carcinoid tumor, which starts in the small intestine usually, and is making serotonin, it can cause something called carcinoid syndrome with flushing, wheezing, and lots of other problems, including heart disease. If the neuroendocrine tumor is starting in the pancreas, it can make different hormones that are typically made by pancreas, such as insulin, glucagon, gastrin, somatostatin, VIP, and other hormones that can cause troubles. In this case, they can make people have, for example, a low blood sugar if they're making insulin, or too much gastric acid if they're making gastrin. So these are the functional tumors that come from the pancreas. So are the tumors functional or not functional is an important distinction, because both things have to be categorized. Before figuring what are the therapies for neuroendocrine cancers and how to prioritize them, I just wanted to give you an overview of the kinds of therapies we have and why it's so important that we have multidisciplinary management with the various specialties all working together to optimize the sequence of therapies, which is a subject that we'll be talking about today. Just to give you an overview, in managing carcinoid tumors, resection of a primary tumor is potentially curative, and it's always the best thing to do if you have a tumor which is resectable. And the surgeon can take out the primary cancer and associated lymph nodes. If cancer is already metastatic and it's growing in the abdomen, the liver, or other sites, there still can potentially be a role for surgery removing the disease, and then treatment with other kinds of techniques to keep the cancer at a minimal level. And in a few cases, there might be a role for liver transplantation. Interventional radiology is playing an extremely important part in managing neuroendocrine cancer. Hepatic artery embolization can be used to block off blood supply to tumors in the liver and kill the cancers in the liver in a minimally invasive way. You can use radiofrequency or microwave ablation of liver metastases. We also can use histotripsy. We could use targeted body radiation therapy, SBRT, stereotactic radiation. And there are other techniques for obliterating individual liver metastases. So this all has to be coordinated. Systemic therapy, treating the whole body with somatostatin analogues like octreotide and lanreotide, is a mainstay for therapy when people have the appropriate somatostatin receptors, and peptide receptor radiotherapy using a radiation technique that we'll be talking about. You can also have therapy directed at other molecular targets on neuroendocrine cells. A variety of chemotherapy drugs can be used in certain circumstances. Immune therapy can be used in appropriate patients. And there always are clinical trials available with new agents coming out and new approaches coming out. So it's becoming a large spectrum of possible treatments, and that's why we're talking about how you decide what to do first and second and third and how to prioritize. Symptom control is very important when tumors are functional and are causing carcinoid syndrome or other hormone syndromes. The way you control symptoms is, number one, get rid of cancer. So if it can be removed by surgery, it can be removed by treating with PRRT or ablation or embolization or anything you can do to reduce the amount of cancer, you'll reduce the amount of hormones getting made. There's some special circumstances with some hormones that have to be treated medically or surgically with special approaches, like a tumor making ACTH that causes very high cortisone production. That's metastatic and can't be removed, can be treated with removal of adrenal glands and then steroid replacement. Carcinoid syndrome can be treated with somatostatin analogues like octreotide and lanreotide, a medication called telotrestat. And again, removing primary tumors and metastases is always important. And if you have a tumor that's making gastrin, causing very high acid production in the stomach, these can be treated with antacid medications. So there are a lot of different kinds of treatments that have to be coordinated. What is debulking surgery? This is now metastatic disease, and you're trying to remove tumors as much as possible to reduce the amount of cancer. You surgically remove all tumors that are possible from the liver, the abdominal cavity, the intestines. Everything can be removed surgically. And it turns out if you can remove even 90% of the tumor, survival is just as good as if you remove 100% of the tumor when the disease is metastatic. None of these treatments are curative, but they can potentially result in a chronic illness, something that people could live with for many, many, many years with high quality life and without symptoms from their disease in most cases. So it's very important to have an extremely experienced surgeon doing neuroendocrine surgery to do this type of thing, because it's not a standard cancer operation by any means. There are studies showing that even if you remove 70% of the tumors, you can have an excellent improvement in survival. So surgical cytoreduction. At the time of surgery for metastatic neuroendocrine tumor, the gallbladder should be taken out, because a very high percentage of people taking octreotide or lanreotide, these somatostatin analogues, will eventually end up getting gallstones if you don't take it out. By taking out a primary intestinal tumor, you can prevent intestinal obstruction and bleeding and other complications of tumor growth. So at the same time metastases are being taken out, the primary tumor and lymph nodes can be taken out. If tumor metastases are confined to the liver, or dominantly in the liver, which is a common situation in neuroendocrine tumors, we can destroy liver metastases by blocking off the blood supply with a minimally invasive technique in the interventional radiology department called hepatic artery embolization. After debulking surgery or embolization, where the majority of the tumor can be obliterated, most patients have been living more than 10 years, and that's with treatments we had in the past. And with treatments that we have today with PRRT and new targeted therapies, it's hopefully going to be improving much, much more than that. After getting treatment to liver metastases with embolization, the tumors die so fast that in the first day or so after the treatment, you can have pain, fever, elevated liver enzymes, and just feel really lousy for a little while. And then after that, you feel better than ever because you don't have so much cancer inside. And complications that are really serious from this are rare. It's not recommended to use so-called radioembolization with Y90. It's better to use these other types of embolization because it precludes treatment with some new types of PRRT if radioembolization is used. So we're not currently recommending that in most cases, few exceptions. So the first big group of treatments to speak about is treatments that target the somatostatin receptor. Somatostatin is a natural hormone in the body that turns off the endocrine system. It turns off hormone production of neuroendocrine hormones, and it turns off growth of neuroendocrine cells that are making these neuroendocrine tumors. So it's a very, very good treatment. Natural somatostatin only lasts in the body for 2 or 3 minutes, and it makes a very poor pharmaceutical agent because of that. But there are somatostatin analogues, the ones currently in use being octreotide and lanreotide. These are somatostatin analogues. These will stop cancer cells from growing. It'll encourage them to die, and it will stop the production of hormones. And since 80 or 90% of well-differentiated neuroendocrine tumors have these somatostatin receptors, it's an excellent treatment for a specific molecular target. And we can prove who is going to benefit from this potentially by doing a gallium-68 dotatate or copper-64 dotatate PET-CT. It's a diagnostic test that predicts who is going to respond. So it's very nice. The toxicities are very manageable. If you see on the top, things that are more common are so-called gastrointestinal toxicities, and these result from a reduction in pancreatic enzymes involved in digesting your food. So just by taking a nutritional supplement of pancreatic digestive enzymes before eating can prevent these symptoms. So if anybody has problems with malabsorption, diarrhea, steatorrhea, which is not having enough enzymes, you can have floating bowel movements, you can have lots of gas and bloating and flatulence and all this sort of thing. This will all get better very quickly, usually by taking pancreatic enzyme supplementation with multiple brands that are out there, including things like Creon or Zenpep are common brands. But the generic pancreolipase, this is something that will prevent these symptoms from happening. Gallstones, the next one on the list, is prevented by taking out the gallbladder. And most people with metastatic disease who don't have a gallbladder would not have a problem here. The other side effects are actually very uncommon, and very few people have to stop this drug because of problems with side effects. What has really put somatostatin receptor targeted therapy using somatostatin analogues, what really put it on the map is the so-called clarinet trial. The letters that you see on the very top in yellow are how you make clarinet come out of the title of this trial. It really is a bit of a stretch, but it's become known as the clarinet trial. This was a randomized study that was done in the old days before we had any proven therapy for neuroendocrine tumors, and people were randomly given octreotide or lanreotide, and then anybody whose cancer grew when they were not getting lanreotide, when they were on placebo, then crossed over and was able to get lanreotide. So everybody got it, but half the people got it up front. On this study, This is kind of a busy slide, but what I want to tell you is people with intestinal carcinoid tumors, the average time before somebody's cancer progressed was over 5 years, which is pretty amazing. And that means at 5 years, half of the people's cancer did not progress yet, and they went on for much longer before it progressed. And there are plenty of other treatments available if it does progress. So this is a drug that can have a really major beneficial effect. It's slightly less with pancreatic neuroendocrine tumors, but still years and years before progression happens. There are a lot of exciting things on the horizon right now that are going to make this more user-friendly. Right now, lanreotide is a shot in the behind once every 4 weeks. It's a deep subcutaneous injection. The needle is not nearly as long as the needle that's used for octreotide injections. And it's, as you can see, the efficacy is proven very clearly. But we want to have something better for quality of life. One of those things is oral somatostatin analog. There's one called CAM 2029. There's another one called paltusotine. Both of these are in clinical trials. I hope that one or both of these will be approved very soon. And by taking an oral somatostatin analog pill every day, it'll obviate the need for having to have injections in the rear, which is fantastic for patients' quality of life. Okay, there also are other agents in clinical trial, including subcutaneous injections with a very tiny needle that patients can do every couple of weeks themselves. And that would be another way that it might make it so that people don't have to go to the doctor's office so often. But all of these are in clinical trial now. Well, the next treatment for targeting the somatostatin receptor that I want to talk about is this concept of PRRT, peptide receptor radiotherapy. What you see in green is the molecular target. The thing that says ligand is the somatostatin analog, like octreotide, and the rest of it is a chelator to hold a radioactive isotope. And what we do is we put in an atom that is radioactive of gallium-68 or copper-64, and then when this attaches to the target, like that, it brings with it the isotope, which shoots out rays and says, here I am, I'm a cancer. That's called a reporting unit. If that is positive, it is a predictor that PRRT is going to work. What we do for PRRT is we put in lutetium-177, Lutathera, that becomes the molecular, a little missile with a nuclear warhead on it that goes on a molecular level right into the cancer cell and nukes it. So it's very, very nice. And the effects are terrific. This is some pictures with the gallium dotatate PET. It's superimposed on a CT scan, and all of the things that you see in color on the bottom there are when the PET scan is on top of the CT scan. You can see those two tumors in the liver so clearly before treatment, and then with just 2 cycles of PRRT, they went away. Normally we do PRRT for 4 cycles, and this particular patient had PRRT for only 2. And a year later, it started coming back, but you could see the first place that recurrence is seen is in the liver in the gallium-68 dotatate PET, way before you see it on a normal CT scan. A normal CT scan, a CAT scan, is not the best way to see liver metastases. The study that proved the effectiveness of PRRT in treating cancer goes by the nickname of NETTER-1. And this was the trial that was a randomized trial between PRRT and normal octreotide LAR, except double dose, to see which was better. And it turned out that the PRRT is much better, and the majority of patients had control of their disease for years. At the time the study was first written, the average time of cancer control hadn't even been reached yet. Major shrinkage of cancer happened in a minority of patients. However, it stops cancer growth in almost everybody. It's actually a quite safe treatment. Most people tolerate it very well as an outpatient. We use intravenous amino acids infusions to protect the kidneys and intravenous fluid. There's a very, very tiny risk of serious bone marrow injury that can lead to even getting leukemia. But that's something that happens only in not more than 2 people in 100. And the majority of patients who get this have tremendous benefit. In addition to shrinking cancer and keeping cancer from growing, it improves quality of life in almost everybody. in the study we did as a follow-up of the NETTER-1. It was extremely effective in controlling diarrhea and flushing from carcinoid syndrome, relief of pain from carcinoid tumors, increased energy, increased functional status by patient evaluation, by physician evaluation, and all kinds of instruments to study health state were improved by PRRT. It's a really excellent quality of life treatment. You recover from the acute side effects that are usually still pretty well tolerated as an outpatient. The next big PRRT trial that was done was NETTER-2. This was in people that had tumors that were grade 2 or 3, well-differentiated neuroendocrine tumors who had not been treated with other things or only with somatostatin analogues and were treated right up front. And in this study, people did very well with a time before tumor growth that was much better than using standard of care in the comparator arm. The shrinkage of cancer was 43%. This is major shrinkage by so-called RECIST 1.1, which means the cancer is now down to maybe half of the volume it was before in 43% of patients versus 9.3% without PRRT. So there's a tendency to use PRRT earlier in people who have high-grade tumors. One of the really exciting things happening in the world right now is the use of a new kind of PRRT that shoots out a different type of radiation. Lutetium-177 that's used for normal PRRT shoots out a beta particle, so-called, a kind of radiation that travels about 1/16 of an inch and has very, very little collateral damage and works extremely well in controlling cancer, as I've been showing you. The new kind of PRRT that's in clinical trial right now shoots out what's called an alpha particle, which weighs more than 1,000 times more than a beta particle, has tremendous energy, and when it shoots into a cell, it just destroys it, has a much higher cell kill, and amazingly has less collateral damage. It has distance that the alpha particle travels that's just a microscopic distance of maybe 2 cell widths. It doesn't have any noticeable collateral damage at all. So it's really a remarkable treatment. And for people whose cancer progresses after 4 cycles of regular PRRT, they can then be treated with this and can have an excellent response. This is a picture over here of somebody who has cancers all over, metastatic disease after previous treatment with lutetium-177 dotatate and after 2 cycles of therapy with the alpha-emitting actinium-225 dotatate, the one that we have in clinical trial now. The cancers have all gone away. What you see are 2 kidneys where it's being peed out. Whatever wasn't stuck to tumor is being eliminated. And the bladder has some urine that's radioactive because, again, the urine is radioactive. And the only other things you see there are a normal liver and spleen. It's extraordinary how well it can work in many patients. So to further evaluate this, and hopefully it will lead to an FDA approval if the study is a randomized trial between this alpha-emitting drug and standard of care therapy. So the alpha-emitting drug is the actinium-225 dotatate that I've just told you about, and the people not getting that are getting whatever they would otherwise get for standard of care. And if anybody getting standard of care has progression of cancer, they then switch over and get the radioactive actinium-225 dotatate. So this trial is ongoing, and I think it's a very major potential advance in treating people with metastatic neuroendocrine tumors. The next thing I'd like to talk about are some other molecular targets that we have drugs to treat and are effective treatments for neuroendocrine cancer. One is everolimus, which is also known as Afinitor. This is a pill which can be taken once a day, a targeted type of biologic. And in people who have neuroendocrine tumors of the pancreas, neuroendocrine tumors of the lung, neuroendocrine tumors of the intestine, and probably other kinds of neuroendocrine tumors also, it's an effective drug that people can have control of their cancer with. The slides that I'm just showing you refer to the trials for first pancreas cancer, and then this trial here for lung and intestinal carcinoids. And the results are very similar. Another type of pill which you can take once a day in treating pancreatic neuroendocrine tumor is called sunitinib, brand is Sutent. This is a medication which is able to control pancreatic neuroendocrine tumors in a way very similar to what can be accomplished with everolimus, in that it's a pill that is once a day and works on certain targets in cancer cells that stimulate their growth. So that's another type of treatment. One that I'm very excited about has just been proven on a randomized phase 3 trial that was published in September of 2024. This is just months ago. The trial was finally published. This is a trial that we did with cabozantinib. Cabozantinib is a very, very active drug in neuroendocrine cancers, and patients were randomly assigned cabozantinib versus no cabozantinib, again with the opportunity to cross over and get cabozantinib if they started out without. And the drug is very, very effective in people who had already been through almost every kind of treatment you could imagine, who then got treated with cabozantinib. At 13.8 months, over a year, half of the people had started to have tumor growth, and the rest of the people it hadn't even started growing yet, and who knows how long they can go before it starts growing. And in people who got a placebo, the average time until cancer grew in a major way was 4.4 months. So it's very effective in pancreatic neuroendocrine tumors and in neuroendocrine tumors that started everywhere else in the body, which they called extrapancreatic neuroendocrine tumor. It didn't work quite as long, but it still worked very, very well and is one of the best oral pills that we have today for treating neuroendocrine cancer that is resistant to some other things. There are some chemotherapy drugs that are uniquely good for pancreatic neuroendocrine tumors. And probably the most important of those is a combination of temozolomide versus temozolomide capecitabine clinical trial. The winner in this trial was the combination. So we call it CAPE-TEM. Capecitabine is an oral form of a drug called 5-fluorouracil, and temozolomide is another oral chemotherapy on a peculiar schedule, but it's given capecitabine for 14 days and temozolomide for the last 5 days of each 14-day period, and then it repeats every 4 weeks. But anyway, on that schedule of taking pills, people have an excellent response and excellent control of pancreatic neuroendocrine tumors, with major tumor shrinkages happening in about a third of the patients, and again, a high percentage of the patients having lesser degrees of shrinkage or stability. Now, when people have hormonal symptoms from carcinoid syndrome or the pancreatic neuroendocrine tumor symptoms that we talked about earlier on, there's some special considerations. Carcinoid syndrome can cause severe flushing, as you can see in this picture over here. It can also cause severe watery diarrhea, which is a very major problem, and it can also cause carcinoid heart disease, where heart valves get so scarred that they need to be surgically taken out and replaced with artificial valves. This is one of the most dread complications of carcinoid syndrome because it requires open heart surgery to fix if this gets to be a major problem. And we have at least half a dozen patients every year who have to undergo such surgery because they come so late in their disease that the carcinoid syndrome wasn't able to be controlled wherever they were being treated. With very careful control of the carcinoid syndrome, this is actually a very rare situation that somebody needs open heart surgery like that. Control of carcinoid syndrome with subcutaneous octreotide is important to remember that in addition to using the monthly or every 28-day injections of lanreotide or octreotide, people can self-inject small amounts of octreotide themselves with a little tiny needle and can use this to supplement what you can do with the big injections, and that can really help flushing and diarrhea and reduce the production of 5-HIAA serotonin metabolite that's being measured. Lanreotide and octreotide are both proven to control carcinoid syndrome symptoms of flushing and diarrhea. The trial that was done with lanreotide was called ELECT. This is a study of telotrestat. It's a pill that is taken 3 times a day, reduces serotonin remarkably after people are already on octreotide or lanreotide. So you use this to supplement that. You can reduce the level of serotonin production by about 50% by using injections of octreotide or lanreotide. you add to Lutathera, you could reduce the serotonin production by another 40% or so. This is an example of what you see with tilotrestat and production of serotonin. So when you're trying to sequence the therapies, which is one of the goals of our talk today, we want to say, how do we figure out what we want to do? The first thing we have to ask ourselves is, what is the treatment being used for? Is it being used for a cure of a cancer, or is it being used for palliation, for helping people live the longest possible life with the best possible quality of life, but it's not going to be a cure? And that sometimes makes a difference in how you think about treatments. If a patient has a tumor which is in the pancreas and has extensive metastatic disease all over the body, to take out the primary tumor would mean removing the most of the pancreas or all of the pancreas, and there's no hope of curing the cancer by doing that operation. Is it really a good idea to do such an operation, or are we better off treating right up front with PRRT and with other kinds of treatment and treatments that are liver-directed therapies and not doing a radical pancreas surgery? However, if that surgery is potentially able to cure a tumor which is in the pancreas and hasn't spread anyplace else, it's a whole other story, and you would go all out to do that. So you have to ask yourself, what are you doing and what are the goals? Are you trying to reduce tumor size because the size of the tumor is already a problem? It's causing pain, it's causing obstruction of intestines or obstructions of some vital structure in the body? Or is the goal of therapy to just let it stay where it is, keep it from growing, hopefully with a small amount of cancer, not causing trouble, and you can just leave it there for years and years and years and years, but it's going to require some kind of treatment to do it. It's going to change the approach to your therapy. And is the goal right now controlling hormone symptoms, like carcinoid syndrome, for example, or is the goal to just control the cancer only? And a lot of these things are ongoing discussions that happen between patients and doctors, and the patient's past history, other medical conditions they might have, their own psychology, their own approach to their disease is so important and requires the physician and patient to discuss these things all the time. So what are some of the factors that influence the treatment decisions that we make? One is, how extensive is the cancer? Is it localized or is it metastatic? If the cancer is localized in one place, like in an organ that can be removed surgically or in a piece of intestine that can be taken out, that you go straight for surgery. Is the tumor metastatic? If it's metastatic, is it operable or it's not operable? So we have to take this into consideration. Are the metastases confined to the liver, in which case we can do all those types of liver-directed therapies I talked to you about that include surgical removal of metastases, hepatic artery embolization, ablation of all different kinds, from microwave ablation to histotripsy? Are they widely metastatic sites that can only be treated with a whole body type of treatment, like PRRT or like various types of chemotherapy or other treatments to the body? We have to be sure the pathology is accurately read and determined. Is this a well-differentiated or a poorly differentiated tumor? Poorly differentiated tumors usually require much stronger types of chemotherapy and very different management than well-differentiated tumors. Are the tumors grade 1 or grade 2 well-differentiated, or grade 3? Grade 3 well-differentiated is much more aggressive and often requires more intensive therapy, may require PRRT sooner, may require other types of therapy. Another thing to remember is that when you have a biopsy of a cancer, and it's called grade 1, grade 2, grade 3, whatever the biopsy shows, is typically done with a small biopsy. If somebody has liver metastases and they have a needle biopsy of a liver, you just get a little teeny bit that's looked at by pathology. But sometimes these tumors are heterogeneous, and there are some areas that are growing faster than other areas. And if you look at an MRI or a CT scan, and tumors have doubled in size in 3 months, and you had a liver biopsy earlier on that said grade 1, there's something that doesn't fit, right? You have to use your head a little bit, and if cancer is growing fast, you know it's not really a normal grade 1 tumor. It could have some areas are grade 1 and some areas could be grade 3. And you have to make sure that when you're planning the treatment, you take into consideration what is actually happening on the cancer growth perspective. Is the primary site pancreas or is it not pancreas? Pancreas neuroendocrine tumors are much more amenable to all kinds of treatments like I showed you with capecitabine and temozolomide. They have a higher response rate with everolimus. They have a higher response rate with almost all the treatments you can think of. So pancreas, even though it can be more aggressive sometimes, is also something that's particularly amenable to many types of therapy. Are the tumors making hormones, or are they not making hormones? Are the tumors big enough that they're causing serious symptoms, or are they not big enough to cause serious symptoms? All these things affect how you prioritize the various treatment options that you have available. So what do? We sit around a table and talk about it. There's an old proverb from India about the 10 blind men and an elephant. Some of the smartest philosophers in the world were sitting there trying to figure out what an elephant was, and they were all blind. And the people feeling the trunk thought it was a hose, and the people feeling the tail thought it was a snake, and people feeling a side thought it was a wall, and so on. And so these men of Hindustan disputed loud and long, each in his own opinion, exceeding stiff and strong, although each was partly in the right, and all were in the wrong. Now, what we do is, instead of having an elephant in the middle of the room, we have a zebra in the middle of the room. We have a carcinoid patient. And instead of having 10 blind philosophers, we have 10 medical specialists who know a lot about neuroendocrine tumors, but all have some degree of blindness about the full capabilities of the other specialties. And we have to sit around and talk about what to do about every individual patient to personalize care and get the best possible treatment for the zebra patient in the middle. And that's why we have a tumor board every single week. And we talk about management with all the relevant specialists right there. We all look at the imaging together and pathology and so on, and say what are the advantages and disadvantages of different approaches. Because when you're dealing with such rare, complex, and extremely varied situations, it's just not possible to look up a little textbook algorithm and say, this is what you do first, second, and third. So all of this information that I've been sharing with you today needs to be put into the decisions, and I'm trying to help everyone understand the complexity of the decision making and how we go about using that information to make wise choices. So I wanted to thank you so much for allowing me to speak to you today. It's been a tremendous pleasure, and I'm always happy to answer questions and to provide any additional information that anybody would want. Thanks.
Dr. Wolin, thank you for that incredibly informative presentation. I really appreciate those last few slides, really highlighting the importance of personalized care surrounding the zebra and really the importance of a multidisciplinary team. So if you're ready, we will start with some questions, but I'll just prep the audience to just remind you that this question and answer session is for educational purposes only and do not substitute for medical advice. Please talk to your medical team with questions or concern about your individual care or treatment. Also, there are over 60 questions. We will try to get to as many questions on this topic as possible. And Dr. Wolin will also be answering questions generally. He cannot provide specific feedback on your specific situation. So, Dr. Wolin, thank you again for being here and being willing to take questions.
Thank you.
We'll start with this first question. This one was very popular. Can someone have many rice-grained tumors undetectable on the scan but still be symptomatic?
That's a very good question, actually. It's certainly possible that people could have multiple little tiny tumors, let's say in the liver, after the big tumors have been taken out or removed. Most of the time, the symptoms that come from carcinoid tumors, from the neuroendocrine tumors that come from the intestine, are not symptomatic when they are really tiny. They become symptomatic when they get large. But there's some situations where even little rice grain tumors can be highly symptomatic. For example, a pancreatic neuroendocrine tumor making insulin, an insulinoma, can have a tumor the size of a rice grain and make lots and lots of insulin to make people's blood sugar go dangerously low. So the answer is yes, it can happen, but it doesn't happen as commonly with intestinal neuroendocrine tumors as pancreatic neuroendocrine tumors.
Yeah. And there was another question about the size of a primary tumor and how small can a primary tumor be? Like, is 6 millimeter, is that possible for that to be a primary tumor in the cecum or ileum?
Definitely. When I was at Cedars-Sinai in Los Angeles, we did a trial of trying to find the primary when people had an unknown primary. Okay, and they had every kind of test imaginable, looking for somatostatin receptor imaging, looking at MRIs, looking at CTs, looking at everything you could think of. And they had upper GI examinations, colonoscopy. Nobody could find a primary tumor. And yet they had massive metastases in the liver, great big tumors. And where did it come from? So we did a study where all of these people had an advanced GI endoscopy procedure called double balloon push enteroscopy, which is a procedure that allows a scoping out of the entire small intestine. So it's a little bit like a colonoscopy scopes out the colon. A gastroenterologist who's trained in this technique could scope out the small intestine. And using that technique, we were able to identify a small intestine primary in 85% of the patients that had an unknown primary tumor causing metastases. And the smallest one that we found, this was published, was 1 millimeter in diameter. That's how tiny it was, 1 millimeter, biopsy proven at double balloon push enteroscopy, and that patient had massive liver metastases. We had others that were 3 millimeters. We had others that were 5 millimeters. So when they start in the small intestine, the cecum, that area, it's possible that even little tiny ones can metastasize. In the rectum, small tumors don't usually metastasize, but I've seen people with metastatic disease from 5 millimeter rectal tumors. Even though 95% are cured by treating the primary tumor with a surgical or endoscopic procedure, that's 95%, but the other 5% still could have a metastasis. So you have to treat these with respect. On the other hand, a 5 millimeter primary in the lung or a 5 millimeter primary in the middle of the appendix, those kind of tumors almost never metastasize. They're just cured by removing the tumor. So it really depends on where it is and what the blood supply and lymphatic drainage is to the particular site. But the answer at the end of the day is that tumors in those areas are definitely not trivial. They need to be treated as cancer.
Yeah, wow. That's really helpful to understand the nuances in terms of the site of the cancer. And speaking of symptoms, whether you're functional or non-functional, so the tumor produces hormones or not, does your diet matter?
Yes. In the case of carcinoid syndrome, there's no special diet that you need to be, other than I recommend a healthy diet for everybody with all the standard dietary guidelines that are good for heart disease and other diseases are also good for cancer. To have lots of fruits and vegetables and whole grains and healthy things. And if any of you have not seen the amazing dietary advice in the Carcinoid Cancer Foundation website from the late Monica Warner, it's really worth looking at that. She has the best dietary information you could find on diet for carcinoid syndrome. If you have a functional carcinoid tumor of the intestine, in other words, your cancer is making serotonin, you're having a severe diarrhea, you have carcinoid syndrome, many people are helped by dietary modifications. Again, you'll find detailed references to what to eat in that presentation of Monica Warner. But the bottom line is big meals are the number one trigger. Alcohol can trigger carcinoid syndrome getting worse, and eating foods that have fermented things in them like miso or other fermented items can cause carcinoid syndrome to get worse in some people. There are lots and lots of things that are other potential offenders. They don't usually cause carcinoid syndrome to get worse, but you can take a look at the list and see what is affecting you in your particular situation. One thing to remember is to avoid all the disinformation on popular websites and stuff about avoiding serotonin-containing foods if you have a high serotonin, because the serotonin in the body that's being made by carcinoid is so much, and the amount in food is so little that it really has no effect at all on almost everyone. So the idea of avoiding bananas and avoiding chocolates and avoiding avocados, and you don't have to go on a low serotonin diet unless you're doing a collection of 24-hour urine for 5-HIAA measurement, which is actually something that personally we hardly ever do these days because we have a plasma 5-HIAA that's done by a fasting blood test. You don't need to be on a low serotonin diet. But if you are doing the urine collection, you need to be on such a diet for 3 days, 2 days before and 1 day of collection. So that's the only time watching the serotonin content of food is important. But otherwise, you could eat normally. So most people with neuroendocrine cancer, bottom line, can eat pretty much what they want. And one more little dietary thing is when people have liver metastases, which is really common in carcinoid tumors, and you have lots and lots of liver metastases, and you're doing therapy on the liver, doing such things as liver resection with surgery, or hepatic artery embolization, or ablation of liver tumors, and your liver is taking a hit from a lot of different treatments, it's better to avoid alcohol, which is a liver toxin. You want the normal liver to be as healthy and strong as possible when you're having to reduce the amount of liver by doing surgery or embolization.
Wow, you answered a lot of questions right there. So of what to avoid and when to avoid it. And we also have many nutrition resources and recipe books on our website as well. Thank you. And videos and podcasts on nutrition. Thank you so much. This is very helpful to know what to avoid and when, and to have some reassurance, right? That people don't necessarily have to give up their chocolate unless they're doing the urine 5-HIA test. So here's an interesting question. Of the patients you see that scan regularly and go a long time without metastasis, what do you suppose they're doing to make that possible?
That's a very difficult question to answer because there really are a lot of things. People have found that people who have exercise, diet, sleep, those sort of things are good for almost any kind of cancer to help keep the immune system strong and help prevent cancer from coming back. It's really hard to point to any specific studies or scientific data to prove that if you just do this modification, your cancer is not going to come back. We don't really have any very specific advice other than try to do the best you can to keep your immune system strong and to keep your body otherwise healthy.
Yeah, that's good advice, right? To stay healthy. Let's talk about some of the scanning and surveillance. You mentioned rectal neuroendocrine tumors. Are colonoscopies needed for screening after rectal neuroendocrine tumors? If so, if yes, how often?
Okay, rectal carcinoid tumors mean that it's happening in the rectum, which is the very last part of the colon. It's just right inside. So you don't need to have a full colonoscopy to look at every drop of colon if you're screening for local recurrence of a rectal carcinoid. So it really depends on the situation, but it could be possible to do a colonoscopy every several years and in between do a more limited sigmoidoscopy or proctoscopy to look at the rectum and check everything and be sure it isn't coming back in the rectal area. So that needs to be coordinated with the gastroenterologist or colorectal surgeon who's doing the screening. It's hard to make a blanket recommendation about how often these things need to be done because it depends on the aggressiveness and size and previous treatment of the cancer. For example, there are some people with rectal carcinoids where a gastroenterologist is doing a routine colonoscopy, finds a little carcinoid tumor, and takes it out at the time of colonoscopy. Later on, you go back in and you have no idea where it was taken out from. And you can't find the spot and you don't know. So that person is going to need to have much more surveillance than somebody who has something which is a 2-millimeter tumor, was completely removed with an advanced endoscopy procedure like transrectal ultrasound guided endoscopic mucosal resection, it's called. You can actually take it out and definitively get rid of it. That's a different situation. It's also different if your tumor is a millimeter or two, or if your tumor is a centimeter or two. It makes a very big difference in how high the recurrence risk is and how often you need to look. I would say in general, people with rectal carcinoids get screened endoscopically probably every 6 months to 12 months. But it really depends on the individual case.
Yeah, it depends. This is the need for personalized care, and the size matters. What about chromogranin A? What does it mean if chromogranin A markers fluctuate?
It means you're probably making a mistake by following the chromogranin A because it's such a a low yield test. Okay, in the last century, where CAT scan was a big deal that most people didn't get, and there was no MRI and there was no dotatate PET scan, and we just had, let's say, CAT scans. People would sometimes get a chromogranin A every 6 months, and if the chromogranin got higher, they'd say, well, maybe there's a recurrence of cancer. Let's do a CAT scan, something like that. It's a very, very low yield test. 90% of elevated chromogranin A's have nothing to do with cancer. If you take one pill of an over-the-counter antacid, you can make your chromogranin high for the next month. It's just, there are many, many, many things that make chromogranin go up. And it can go up and down all the time, just depending on all these other factors in your life. So I think it's an extremely poor test for following cancer, and it's not something that I recommend as a routine. I can't remember the last time I made a treatment decision and said, okay, we've got to start chemotherapy, we've got to go to surgery, or we got to do something different for treating cancer based on a chromogranin going up. The next time you check it, it may be lower, the next time it may be higher. And by the time it gets really high and it's obvious it's from neuroendocrine cancer, it does go up with neuroendocrine cancer, no question. But by the time it goes up that much that you say, yeah, it's really so high, we got to worry, you already know the worry because you see it on MRI, you see it on the dotatate PET scan, and it's there. So I'm not a big chromogranin A fan at this point in time.
Yeah. Yeah, that's it in a nutshell. Thank you. So this is a hot topic right now. What is the experience with histotrypsy and high intensity focused ultrasound thermal effect for the treatment of neuroendocrine tumors?
Okay, so histotrypsy is a way of zapping a cancer with very highly targeted sound waves that come in from different directions, focus in on a tumor, and the ultrasound waves are so intense that they can annihilate the tumor without causing a lot of damage to the surrounding liver. That's one way of getting rid of a tumor which is sitting in the liver. Remember, the other things that I mentioned in passing were putting a needle into the tumor and microwaving it and cooking it. That's one way. You could put a needle into it and have liquid nitrogen go in and freeze it to death. That's called cryoablation. You could treat it with targeted radiation therapy. That's called stereotactic body radiation, SBRT. You can cut it out surgically. There are many, many ways to get rid of isolated metastases. Remember, all of these things are for isolated metastases. If you have a whole liver full of metastases, the only way to deal with that would be something like hepatic artery embolization, where you can treat the whole liver by cutting off the blood supply to the tumors inside the liver, or by using something that treats the whole body, like PRRT, for example. The histotrypsy is one of the newest and most exciting ways of ablating, of getting rid of individual tumors. It's a new technology, so always new technologies are very exciting. Just like a few years ago, NanoKnife was very exciting. That's another technology that's out there for getting rid of tumors using electric currents to electrocute the tumors, and that works very well too in certain circumstances. But histotrypsy is a way of getting rid of tumors if there's a limited number, they have a small enough size, and it's the right treatment to do. It's great. So I think you have to view histotrypsy as not a goal in itself to get histotrypsy, but as a technique of liver-directed therapy when it's appropriate. And we have a histotrypsy machine at Mount Sinai, and we're doing histotrypsy. Histotrypsy is being done in multiple centers around the country. Some places are doing more than others, and that's because of the machines have not been available and the skill of the operators wasn't always up to speed. But now that it's becoming more common and there are more people who know how to do it, it's being done more. But before somebody has histotrypsy, I like to have a discussion with the Multidisciplinary Tumor Board. We like to think about the situation. Is this somebody who's going to be going to surgery anyway, and this can be taken out? Is this a tumor that's in such a location that surgery is going to cause more harm than good, and it's better to treat it with histotrypsy? If it needs to get obliterated, is this the best way to go, or is some other destructive technique to make that individual tumor die, is it more appropriate? So I think histotrypsy is great. We're really excited to have it, and I think that the neuroendocrine community should be excited that it's out there because it gives us one more great treatment option, but it's not for everybody, and it's also not without side effects. So you have to make sure that people who are doing it thoughtfully and putting it in perspective.
Yeah, thank you for that thorough answer. On to the next question. Is it possible for a pancreatic net to spread to the lungs?
Yeah, that's a good question. Yeah, pancreatic neuroendocrine tumors usually, when they spread in the bloodstream, they first go to the liver because there is a bypass tract essentially that goes from small intestine and from pancreas directly into liver. We call it the portal vein. It brings blood to the liver so the blood can be filtered before it goes into the general circulation. And when blood is filtered by the liver, what happens is that it brings the cancer cells directly to the liver, and that's what happens. When you have tumors that go directly to lung, they somehow bypass that mechanism, or they don't like the environment in the liver, and they end up in lung. In general, when pancreatic tumors end up in lung, they have an even better prognosis than if they end up in liver. And sometimes it's liver and lung, sometimes it's lung only, but certainly it can spread to lung. It is definitely possible.
And speaking of lung, there are a few people who wanted to know about lung treatments and what is updated information for lung carcinoid tumors and dip neck.
Okay. Lung carcinoids are actually pretty common, and it's become sort of an orphan disease among the carcinoid tumors. I'm a neuroendocrine oncologist. I treat every kind of neuroendocrine cancer there is, including lots and lots of people with lung carcinoid. But there are many people that treat neuroendocrine cancers who are primarily gastrointestinal oncologists, and their primary focus is treating gastrointestinal tumors, or they're in a gastrointestinal tumor department. And when you're in a gastrointestinal tumor environment, lung carcinoids don't come up as much because they tend to go to the thoracic oncology department. So the carcinoid trials that have been designed for treating carcinoids in general have not included lung carcinoids in the past as much as gastrointestinal and pancreatic tumors. But nevertheless, we have a lot of information about lung carcinoids, even though there are only a few really good randomized trials that show some effectiveness. One is the randomized trial of lanreotide in lung carcinoid, known as SPINET, S-P-I-N-E-T, showing that lanreotide is an effective treatment for lung carcinoid tumors. Lung was also included in the so-called RADIANT-4 trial of everolimus, and everolimus has been proven as a drug for lung carcinoids, and in fact, at this time, is the only FDA-approved drug for lung carcinoids. We also have cabozantinib, which I mentioned before, and it was actually FDA approved just a few days ago. It's unbelievable how quickly it came around to approval after the study was completed. But lung carcinoids were included in that trial, and it certainly worked well in lung carcinoids also. We have, again, less data than we do for gastrointestinal and pancreatic neuroendocrine tumors, but we know that lung carcinoid tumors can respond to PRRT if they have strong somatostatin receptors on dotatate PET scans, and we know they can respond to a variety of other chemotherapies as well. They also can be treated with, like every carcinoid, they can be treated with surgery whenever possible, whether it's for cure or for palliation. There's a lot that can be done for lung carcinoids, and patients do fine. Not everybody with lung carcinoid has deep neck. Deep neck is diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. That's what it stands for. It's a great big mouthful, so we call it deep neck for short. But deep neck is a condition where neuroendocrine cells in the lung start growing. And these neuroendocrine cells, as they proliferate and grow through the lung, fill up the lung with neuroendocrine cells all over the place. They're not cancer, they're just neuroendocrine cells. Neuroendocrine cells live in the lung normally. They dilate bronchi, they constrict bronchi, they increase blood flow to parts of the lung. These hormones do a lot of things in normal lung, but these cells that make the hormones, the neuroendocrine cells, somehow in deep neck are just growing more and more and more and more, and eventually start making little clusters of cells, and the clusters can get bigger and bigger, and eventually they turn into little tiny carcinoid tumors that are sort of micro in size, and then they get bigger and bigger, and then eventually they get called carcinoid tumors, and they can make little nodules all over. And they also can have so many neuroendocrine cells lining the membranes in the lung that it gets to be hard to breathe and cause a cough and shortness of breath and other problems from cell growth. So that's the condition called deep neck. So when somebody has a lung carcinoid and they have lots of little nodules, it's important to look at the area of lung outside the tumor So the tumor gets removed with a lobectomy, with a wedge resection, whatever it might be, to take out that tumor. You need to look at the surrounding lung. Sometimes people ignore surrounding lung. They just think if it's not a cancer, it's normal. But you want to look at that surrounding lung and see if it's completely filled with neuroendocrine cells all over the place and little teeny microcarcinoids forming. And that would make the diagnosis of deep neck. Some people have deep neck, never get a lung carcinoid. They just keep getting these little nodules and complications of deep neck. The bottom line is that there are no really huge randomized trials to prove what therapy needs to be done for deep neck. But if people have that condition, they need to be followed closely, I would say every 6 months, with pulmonary function tests, including tests to measure how well diffusing of gases like oxygen can happen across the membranes of the lung, one's called DLCO, diffusing capacity. You can measure that as part of lung function tests that are done by pulmonary doctors, and also check a CT scan every 6 months and see how people are doing and see how they're doing symptomatically with cough and shortness of breath. And at some point, if the cancer is growing, if it's causing symptoms, if it's causing problems, if the tumors are growing, they could be treated with a somatostatin analog. And I have people who have been on things like radiotherapy for years and years and years, and can be managed with just a somatostatin analog. Although other things that can work for lung carcinoids can work for deep neck. That's usually the least toxic way to do it, and at least in the beginning. It's an unusual situation. People are still studying.
Thank you for that very thorough answer for this population that often does feel orphaned, as you mentioned. You mentioned cabozantinib, so this is a perfect time to transition to a question about that. Someone asked about the September 2024 New England Journal of Medicine publication of the phase 3 cabinet trial on cabozantinib. Could you discuss cabozantinib in context of general outcomes seen in your clinic? And I know you were part of that trial as well.
Yes, that's true. I was one of the authors of that New England Journal paper that came out in October 17, 2024. It just came out. And now that's a drug that just got approved. It's a very, very exciting drug. And it's something that's, I think, an important part of management now for neuroendocrine cancers. I have lots and lots of patients who I treat with that drug on the clinical trial and subsequently. And it can work in all kinds of neuroendocrine tumors. It's not dependent on the somatostatin receptor. It can work even when people have progressed after PRRT, or they've progressed after everolimus, or they've progressed after other treatments. And most people can tolerate it. It's a PO medicine, in other words, an oral pill that you take once a day. The recommended starting dose for that medicine, 60 milligrams every day, needs to be individualized. And now that it's on the market, I think people can do that depending on the circumstances and people's prior treatment history, on their kidney function, on just a lot of different things and how much they can tolerate, and also just individual tolerance and individual differences in metabolism of the drug. Some people's maximum that they could tolerate is 60 milligrams. Some people can only tolerate 40 milligrams. Some people can only tolerate 20 milligrams. So you need to work very carefully with your oncologist to optimize the dose. If you use that drug, just remember that it can cause side effects. The side effects are manageable but need to be watched carefully. You need to work closely with the doctor, the treating oncologist, to make sure that the side effects are minimized. And if they can't be managed at a given dose, it's possible to reduce the dose. But the side effects can often be controlled, and the dose does not need to be reduced if you use various kinds of anti-inflammatory mouthwashes for oral soreness in the mouth. You can use different kinds of creams that can be put on people's feet or hands if the palms of the hands or the soles of the feet start getting any blisters or cracking or soreness. And by doing these kinds of maneuvers, most people can tolerate it well. And we've had people controlled for years with it. It's a very good drug. And I think we're going to be seeing a lot more of it in the world of treating neuroendocrine tumors over the next years.
Yeah. Congrats on that. Thank you for your work on that, and for all the patients who also participated in the trial. And now, we have another tool in the toolbox. Yeah. Let's get to some PRRT questions. I know you were involved in that as well. There were two people who asked a similar question, so we'll just phrase it like this. I finished 2 PRRT cycles. to learn that there's been a little growth and maybe some new small tumors. But my doctor says they might shrink as we finish PRRT. How would we know that? And also, there was another question about why do they get bigger before they get smaller?
PRRT, peptide receptor radiotherapy, is using a radiation source attached to octreotide. That's basically what it is. Okay, so it targets the cell and it nukes it. What happens when the cells get exposed to radiation is they get seriously injured. They die, they get inflamed, they get injured. And what happens is, if you were to look at the inside of somebody's body after PRRT, the tumor areas are going to be red and hot, swollen, and inflamed, and looking like a really bad internal sunburn. When that happens to tissues, part of being inflamed is that they swell and they get a little bit bigger. And that can make them look a little bit bigger if you get an MRI after 2 cycles or a CT scan. After 2 cycles of PRRT, the tumors will look bigger. And that is called, in the radiology literature, pseudoprogression. It's not real tumor progression, it's pseudoprogression. And it's sometimes scary to people if they don't know that this can happen. And some radiologists will just say tumors have progressed if they're not familiar with this phenomenon happening as a result of treatment. So you have to be very careful before discontinuing an effective treatment, because sometimes the people with the pseudoprogression are actually having the best response because the tumors are getting so injured by the PRRT. So it has to be a very careful analysis of the situation. Sometimes the only way to tell is by getting a gallium or copper-64 dotatate PET and comparing it with the MRI or the CT. Usually, if it's just a little bit of swelling or a little swelling in some of the tumors, you don't worry about it. If the tumors double in size, then you get worried. That would be unusual. Or if one tumor suddenly grew like crazy and everything else was stable, you might need another biopsy just to be sure that everything isn't the same. But you really can get swelling, and this pseudoprogression phenomenon is real, and it happens commonly. The most extreme case I saw was somebody whose tumors doubled in size. It was just an enormous increase in the size of the tumors. And even though it was a very, very difficult case to operate on, and the surgeon didn't want to operate before PRRT, after seeing this, he said, well, it's the only hope. I'll go in and try to take out 15 liver metastases that have gotten bigger after PRRT. And the specimens were just dead. There was no living cancer in them. They were just all inflamed tissue. So you just have to be careful in abandoning an excellent treatment and stopping PRRT prematurely. On the other hand, there's a rare person where it doesn't work at all, and you really have to. So that takes a certain amount of individual judgment. But most of the time, it's going to be pseudoprogression rather than progression. Yeah, you get a better idea after it's all over, and a few months after the last PRRT, you can get a dotatate PET scan, get an MRI or a CT. You can look at what's actually happening at that point, and usually by then you see things are under control. Just one last point about this is that it makes absolutely no difference in how well people do long term if the tumors shrink or if they don't. If they stay stable, that's excellent. If tumors are previously progressing and somebody goes on PRRT and the tumors don't shrink, and then next year they don't shrink, and the next year they don't shrink, and the next year they don't shrink, and you can get years and years of mileage out of those 4 PRRT cycles, even if the tumors haven't shrunk. And that person's going to do much better than somebody whose tumor shrinks up a lot and then grows back 6 months later. That's not going to be very good, even though you had an initial great shrink of tumor. So it's a whole different world evaluating response to PRRT than evaluating response to chemotherapy.
Yeah, thank you for that. Stability is also a win. And a related question, you were talking about scanning after PRRT. Is 2 months after completion of PRRT too soon to assess PRRT response? And if there's mixed results at 2 months, might things still improve?
Yes, they certainly might improve. 2 months is sometimes okay. 3 months is probably a little better. 4 months is good. The problem is that if you start PRRT and you do one treatment every 8 weeks before the next one, right? Altogether, that's about 8 months of time goes by. So the problem is that you don't want somebody with metastatic cancer to go for almost a year with no imaging and not knowing what's happening and not knowing if they're the rare person not working. So I tend to monitor along the way, even knowing that we're going to have some confusing situations like this coming up periodically. But I like to know what's going on. But the minor shrinkages or mild progressions, seeming progressions, are not anything to worry about, even after the PRRT is finished. and you just have to continue monitoring, and then
Okay.
it'll become evident.
Thank you. Thanks for that reassurance. So what's your experience in retreatment with PRRT after the first treatment? I'm assuming the first 4, if the response was good the first time, and when would you consider it?
If people's cancer starts progressing within 6 months, I think it's not a good idea to use more PRRT. I would move on to something else because it's probably not going to be much good. If the cancer goes more than that with control, the longer it goes, the better. And sometimes people's cancer can be controlled for years before they need retreatment. Retreatment is not a standard thing to do, but it's something that there's a lot of experience with, even more in Europe than in America. If you use lutetium-177 dotatate for retreatment, usually it's done for 2 more cycles, and you need to typically stop after 2 more cycles because blood counts start getting low. It starts getting hard for people to tolerate, and the risk of bone marrow injury is also potentially increasing. The most exciting thing for retreatment by far is participation in a clinical trial with an alpha emitter. There's not even a question. That would be my first choice if I had a recurrent tumor after PRRT. And we have the treatment of actinium-225 dotatate, the so-called Action 1 trial, active right now at Mount Sinai. And I have lots and lots of people who have had PRRT for 4 cycles, and then later on at some point they progress and now are being treated with the alpha emitter actinium-225 dotatate. That's a very, very active treatment, but it's still investigational and can't be a standard recommendation. So if somebody wants to go on a clinical trial, either to go on a clinical trial of actinium-225 dotatate, or alternatively a clinical trial of lead-212 dotatate, which is another alpha emitter. Those are the only 2 in clinical trial in the United States. That would be my first choice. If somebody doesn't want to be on a clinical trial, is not eligible for a clinical trial, then I would treat with 2 more cycles of lutetium-177 dotatate if kidney function is appropriate and blood counts are appropriate and the patient is otherwise a candidate for PRRT.
Yeah, thank you for that. What about, this is a good question, with lung net grade 1 with many receptors, what would the reasons be for PRRT not to work? And then what are other systemic treatment options, which I know you've already gone into? I think this is a good question just in general. If someone has receptors and the PRRT doesn't work, what are reasons that might not work?
It depends on the degree of receptor positivity. The stronger the receptors, the better it works. And we have a scale for determining how strongly the receptors are being expressed, known as a Krenning scale, named after a great nuclear medicine physician in the Netherlands, Krenning scale, which compares the standard uptake value of the tumor to the standard uptake value in the liver and the spleen. It's a scale that goes 0, 1, 2, 3, 4. 4 is the highest. The higher the Krenning score of the tumors, the greater the chances of having a response and having a really good result. So if somebody has a relatively low Krenning score compared to one who has a very high Krenning score, that would determine the likelihood of responding. The other things are different mutational things that go on in the tumor that influence how well or how long it would go. In general, when tumors are really aggressive and have a high Ki-67, responses tend to be shorter than if the Ki-67 number is lower. There are many things that can influence the duration of response, and there are many things that we don't know. We just have to do the best we can.
Thank you. Thanks for that. Are liver-directed therapies, when combined with PRRT, an effective treatment for managing the majority of tumors confined to the liver?
Well, I think it depends on exactly what you mean by combined and which liver-directed therapies. It's possible to give liver-directed PRRT. You can give PRRT into the hepatic artery directly by having an interventional radiologist put a catheter into the hepatic artery and administer PRRT directly into where the tumors are, with maybe increased uptake in the tumor. It's something that we've done before. It's something that there are several clinical trials doing. The question is how much better it is than giving PRRT into the body in controlling the cancer. But in certain situations, that is ideal when people's metastatic disease is pretty much confined to their liver. PRRT can be given in conjunction with other therapies systemically. People have done it with everolimus, they've done it with 5-FU, they've done it with capecitabine, temozolomide. There are a lot of studies that have done it with immune therapy, trying to combine it with other types of things. If you want to treat liver aggressively with liver-directed therapy and you want to use PRRT, normally it's better, for example, hepatic artery embolization with normal techniques is something that normally would either be done before or after. You don't need to do it at the same time as PRRT. But there are situations where we do that. Somebody has some urgent thing that has to get shrunk right away because the tumors in the liver are causing damage, and we just have to shrink it. We use liver-directed therapy with hepatic artery embolization, and then follow that with a planned PRRT. So there are different ways of sequencing this, and that's, again, why it takes individualized management.
Wow, so many nuances. You mentioned in your talk today that Y90 is not currently being recommended as treatment. Can you explain why?
Well, Y90, yttrium-90, is another radioactive isotope. We're talking about not recommended as treatment for PRRT. I mentioned it wasn't recommended for hepatic artery embolization. Yttrium-90 shoots out a beta just like lutetium-177. However, the beta that shoots out from yttrium-90 travels for 20 millimeters, and the from lutetium-177 travels 2 millimeters. So you get a lot more collateral damage in the liver when you use yttrium-90. And when you use yttrium-90 radioembolization of the liver, which is a great way to treat liver tumors, it has less side effects, it's very user-friendly, it works. Okay, but when people do that, they have a certain amount of collateral damage to liver that can potentially make PRRT more dangerous. For that reason, the clinical trial, for example, of actinium-225 dotatate using the new alpha emitter automatically excludes from the trial anybody who's ever had radioembolization in their life. So if somebody's had yttrium-90, it closes a lot of doors, and certain very effective therapies that we have out now are not possible. And it makes normal PRRT probably have more danger to it, and it makes investigational PRRT with alpha emitters impossible. So I think that there's just no good reason in most cases to do it. You go ahead and do blend embolization or some other type of embolization instead. That being said, there's some people that will never be candidates for PRRT. Maybe their kidney function is too bad. Maybe they have some other reasons why they can't have PRRT in the future. You can go straight away and use yttrium-90, no problem at all. So again, the care has to be individualized, but it's certainly not a standard thing that I would recommend.
Okay, it's good to know the pros and the cons. How effective is CAPTEM at treating GI net that has spread to the liver?
It occasionally will work, but it has a low response rate, very low. For pancreatic neuroendocrine tumors, it works in about a third of the patients. In gastrointestinal nets, like in small intestine 1 spread to the liver, it doesn't usually work. So it can work, but it doesn't usually. So we don't use it early on.
Okay, thank you for that. What is the most effective adjuvant therapy protocol when scans show no remaining nets?
What a great question. We don't have an answer, I could tell you. The closest we came to trying to find one was a great big study that was being done through the Eastern Cooperative Oncology Group in people that had resection of metastatic neuroendocrine tumor of the pancreas. And the liver metastases were completely taken out. The pancreas primary was taken out. The nodes were taken out. And then patients were treated with everolimus to prevent recurrence. And that was supposed to be a definitive trial that would answer the question. However, hardly anybody ever signed to go on that trial. And the trial was closed for futility because it couldn't possibly ever get done because nobody was signing up. So after being open for a couple of years, it just closed up, and we don't have an answer at all. And there's no drug right now which has been proven to be an effective adjuvant therapy. We desperately need something to cure people and prevent it from coming back, but we don't have a drug that we can count on to do it. And there's really no data right now that using PRRT up front as an adjuvant, as a preventive therapy is going to do it, or chemotherapy is going to do it. So in general, we try to not just cause unnecessary harm by doing these things when there's no evidence it's going to work.
Yeah, it really highlights the importance of and the need for people to be willing to participate in these trials so that we can answer these unanswered questions. Yes.
Yes.
And Dr. Wolin, there currently is an adjuvant therapy, an adjuvant study for high-risk pancreatic NET, the SWOG 2104 study for
Right.
adjuvant
We
CAPTEM.
don't, correct, but we don't have an answer yet about whether it's going to make a difference. At this point, I would say standard of care is not to do it. And for anybody who is able to and wants to sign up for that trial, it's available. I hope it's going to have more takers than the everolimus trial that previously was being done by the cooperative group mechanism. But so far, that's been slow on the uptake also. So we have to see what happens.
We need to all work together to move the field forward. Here's another question about research. Is there any ongoing research on mRNA vaccines for neuroendocrine tumors?
I have not seen any right now. It's coming along. It's a wonderful question, but orphan diseases like neuroendocrine tumors are usually ones that companies making these things don't pick as their highest priority item.
Yes.
But theoretically, that would be very exciting.
Yes. We'll end with this last question. What advances in this field or what's on the horizon that you are most excited about?
Wow, there's so many things. The information that's coming out now is exploding, taking advantages of advances in genomic profiling, personalized treatments, a whole variety of new drugs directed at molecular targets, not just specifically neuroendocrine, but just things that are directed at molecular targets. We can identify these targets potentially by whole exome sequencing of DNA, and then we would have other treatments. The thing that's immediately most exciting for quality of life are oral somatostatin analogues and other things that would make it easier for patients to manage. In terms of therapy, I think alpha PRRT is very, very exciting if it keeps up meeting its initial promise in people who have recurrence after normal PRRT. Hopefully that will lead to an approval for that indication, and hopefully it'll be on a roll and we'd be able to use PRRT earlier on with alpha PRRT, and hopefully it's going to have an even bigger impact. I'm looking for the next step of therapy to go from progression-free survival as a primary endpoint to keep cancers from growing to actually curing cancer by getting rid of every last bit. And I'm hoping that there's going to be some combination of immune therapy, PRRT, chemotherapy. Something is going to, these things are all in trial, and we just have to see what is going to really pan out to be something to make the cancer go away and not come back. And I think it's right on the horizon. We're getting closer and closer all the time.
Yeah. Wow. I mean, Dr. Wolin, thank you for all the decades that you've put into this field, being part of all of these advances that you talked about and the ones on the horizon. I mean, you must be so excited to see how this field has evolved and grown and how many tools are now in the toolbox, including what was just FDA approved, cabozantinib, this last week. Thank you for being an integral part of all of this and being such a wealth of knowledge and expertise. We really appreciate you and all that you've done for the field of neuroendocrine tumor and for NET patients in general.
And thank you for all your kind words, and I hope this has been useful to all. Thank you.
We really appreciate you. Thank you. And I'm going to now send it back to Heather in the studio.
Thank you again, Dr. Wolin, for your exceptionally insightful presentation and for answering so many questions on the sequencing of NET therapy, the rationale behind it, and better understanding treatment options. We appreciate our supporters: Novartis, Ipsen, Exelixis, Curium, Crinetics, ITM, Boehringer Ingelheim, InterScience Institute. Educational programs like today's are also made possible by donors like you. Please consider making a donation today at ncf.net/donate. And a special thank you to our technical director, Rich Tamayo from TVP Live, for this high-quality broadcast production. Again, today's presentation and Q&A session have been recorded and can be viewed on our website, video library, and YouTube channel shortly after this broadcast. If you register for today's webinar, you may receive a survey via email. We greatly appreciate you completing this survey as it helps us improve our content and with fundraising efforts. Again, follow us on social media to stay up to date on our upcoming events. Our handle is @NCF And now I'll turn it back over to Lisa.
Thank you, Heather. LACNETS, which is now known as the Neuroendocrine Cancer Foundation, is a community of support and resources. We recognize that you are more than your disease, and we aim to support you as a whole person. To this end, we offer many resources and programs. Find out more on our new website, ncf.net. We offer a monthly podcast featuring experts who answer the top 10 questions in their field. Go to our podcast page to check out the episode transcript, resources, and the 10 questions we asked the expert. Thanks again for joining us for today's educational event. Goodbye, and we look forward to seeing you at our next event.